Our next presenter is Dr. Christian Nzimira. He is a graduate of the College of Medicine and Health Sciences at the University of Rwanda, and he further studied palliative care education and practice at Harvard Medical School Center for Palliative Care, and trained as an African pain policy expert at the University of Wisconsin. And he's also a Fulbright alumni. He's currently the city manager for the City Cancer Challenge Foundation in Kigali. He is the former executive director of the Rwanda Palliative Care and Hospice Organization. He is the former director of Kibagabaga Hospital in Kigali and has advised several governments on the national palliative care policy, including Burundi, Rwanda, and Senegal, on the access of palliative care services. We're looking forward to this talk. He's also very well placed as he's a member of the Scientific Advisory Committee of the Lancet Commission on the Global Access to Palliative Care and Pain Control. Dr. Nzimira, over to you.
Thank you, Dr. Lambo. So good morning and good evening, everyone, and thank you, AORTIC, for this invitation. So quickly, I'm going just to ask, I'm trying to ask the best question. Maybe I don't have the right answers, but what I'm thinking about palliative care perspective. So one of the best question is, what is palliative care? I know based on many discussion and from different side of the world, some people still thinking that palliative care is for end of life care and or for terminal care. But based on the WHO definition, palliative care is an approach to improve the quality of life of patient and family facing life-limiting illnesses. So my understanding of this basic definition of palliative care is quality of life of patient and their family, early identification of symptoms, and holistic approach. And when we think about holistic approach, it's a physical, social, spiritual, and emotional. And we so focused on the disease, but sometimes we forget to focus on the patients. And the second question is, what is palliative care not? As I said, palliative care is not only for someone who's dying, it's part of ongoing care. Palliative care, the goal of palliative care is not to intend to hasten or to delay death. And palliative care, pain relief is a central aspect of palliative care, but palliative care is not only about pain. And this is, it's a good picture to help people to understand about palliative care, especially in oncology, when people think, okay, let's treat the patient, let's do chemo, let's do everything. And if it doesn't work, we will send to palliative care team. And this is, unfortunately, when we receive the patient and the family members, you don't know exactly how you can. It could be good if you can see the patient early as possible, but sometimes it's really quite difficult. Even the quality of life from the patient and the families have been affected because the part of our colleagues didn't mention that there is a team of palliative care, or can integrate the patient in palliative care. So end of life care, terminal care is part of palliative care, but palliative care is not about only end of life care. Person-centered care versus disease-centered care. So we talk so much about the disease, but I was just reading yesterday this quote from Hippocrates. We say it is far more important to know what the disease has than what the disease the person has. So if we so focused on the disease, sometimes we'll be missing treating the person. So, but if you treat the person, for sure we'll be treating the disease as well. So it's really important to understand from this question, what is the most important things? Is it the disease or is it the person? So I'm looking forward from the discussion, but my understanding and based on my experience is that we need to focus on the person, because the disease, it could be a temporary status, it could be a temporary situation, but the person will still there. The person is still there, and when it affects the person, it affects also the environment of the patients. So how accessibility to morphine, the gold standard for treating pain in the world? So based on the Lancet Commission, the study have been done by the Lancet Commission. So morphine is really accessible, especially in low and middle income countries. And when we have a million and people who are still dying in pain. And the rich have access, of course, to morphine, but the poor do not. And morphine is almost inaccessible in the poorest, more than 120 countries. And this is the clear image from the Lancet Commission. You can see access to morphine around the world. In only 3 countries, Canada, US, and Australia, get access to most of the morphine consumption in the world, if you compare to the rest of the world. So it's a really, it's sad, but this is the reality. And this is one of the question all the participants, all the panelists, we need to ask ourselves, if we're contributing to bring the equity and for access to morphine around the globe, or we'll be contributing to create again the gap. So it's really important people to understand this is how the palliative care is playing a big role. And what is the need to treat the serious health-related suffering and with people with serious, complex, life-threatening illnesses? This is the picture from the Global Access on Palliative Care End of Life Care. You can see access to palliative care around the world is still limited, and especially in low middle income countries, there is still gaps between Western countries and low and middle income countries. And we need, I think, after this webinar, to ask ourselves, how can we contribute to bring palliative care in our setting and in our environments, whatever your specialty you're doing. And what is my perspective in palliative care in the future is, one, it's we still need to work on policy. I don't remember well, but I think less than 10 countries out of 54 countries in Africa has a policy in palliative care. So we're still struggling, despite the resolution of palliative care voted in during the World Health Assembly in 2014, but it's still a gap in most of African countries to have a policy. So we need to work on that. My vision on in Africa is I hope most of the country will get a policy, at least even if the resources is limited, but at least we have a platform where people can play and try to change the quality of life of the patient. Second, it's about integration. We don't need to create a parallel system. We need to integrate what you have, what you learn, and what could be integrated in a public health system. Different approach could be used, but it's really important from central level, district level, community level, home care, using community health workers, district level, health centers. It's really imperative that palliative care has to be integrated in public health system. Create a parallel system is to increase the gap to access to services to patients and the family members, even if the intention is not it's not to create the gap, but by supporting the system, the public health system, we are focusing to get access to everyone, that everyone can get at least the minimum services at each level of the public system. Another good point from the Lancet Commission, it's about now we have a package of palliative care. It was really difficult, I think, before the Lancet Commission to have a clear idea what is really needed in palliative care, what we need to do in terms of equipment, in terms of social support, in terms of human resource. Now, from the Lancet Commission, we have a clear idea what package of palliative care, and this is really need to be advocated in our country, in our setting, what we are doing, especially in Africa. And there is a paradigm shift, and especially during the COVID-19, community-centered care approach. You know, the COVID-19, it's a pandemic, it's a global pandemic situation. We can't use the patient-centered approach in a global pandemic situation. We need a different paradigm, and my understanding is the COVID-19 showed that we need to shift in a paradigm. We need to focus on a community-centered approach, which will be multidisciplinary, multi-sectorial, and multi-specialties, and not only focus on the disease, but focusing on the whole environment. And the experiences, especially in Rwanda during the COVID-19, when during the lockdown, 2-month lockdown with more than 100 patients in the city of Kigali, it was easy to lean on the community, and the community was our eyes and the ears to support patients. And it was really clear for us that we need to shift it in the way we were apprehended palliative care, in the way we were implemented palliative care in the community. We need also to understand to categorize resources, and most of the model for advanced care planning and end-of-life care decision-making in Africa has grown from the Euro and American clinical and culture experiences, sometimes which will not fit to the perception of care delivery from our population. And one of my understanding for the best philosophy, which is an understanding resources beyond fundings, and especially when most of the program is based on funding, and when funding is withdrawn, all the programs stopped. It's the Ubuntu philosophy, which is defined that people are people through other people. So to understand more behind funding, there is a lot of resources, especially in Africa, which could be used to continue to provide palliative care services, not only focus on the disease, but focus on the person and the environment of the person. Of course, culture matters. I try to get some experiences from Western country and from Rwanda based on my experiences in terms of personhood, family values, what sometimes when you discuss with the patient, what is the disease, how do you understand about the disease, how do you understand about your illnesses, which is in Western country, it's about by specific agent, it's COVID-19. This is a specific agent, but sometimes when you discuss it with the patient, they say, oh, maybe God is angry, maybe someone in the high spirit is not happy with me. And there is imbalance between personal, ancestral, or circumstance, which is really clear. So if you understand, if we understand, based on my experience, if we understand the culture part of our services, of our care, of our delivery, then we'll be able to give an appropriate and specific care to our patient and the family members. And in terms of pain, death, and also bereavement. So my conclusion is palliative care is not optional. It's not an extra, it's not an add-on, a luxury of an afterthought. It's a really essential component of human care. So to develop cancer treatments without the parallel development of palliative care, my understanding is a cruel injustice to the million of cancer patients around the world who suffer from illnesses. It is really essential that when people talk about access to cancer, screening, radiotherapy, surgery, chemotherapy, all vitally important, they must also be talking in equal measure and with equal conviction about access to palliative care. Thank you.